In this video, we'll discuss about cholecystitis. It is referred to as inflammation of gallbladder. Inflammation of gallbladder, it can be acute or chronic. Acute is further divided into acute calculus cholecystitis, acute calculus cholecystitis, which is because of presence of gallstone, and secondly acute acalculous cholecystitis where the gallstone are absent. So first one, acute calculus cholecystitis, this one because of gallstone. Second one is acute acalculous cholecystitis, here gallstone is absent. Now coming to acute calculus cholecystitis. In this condition of gallbladder, which result as a complication of presence of gallstone. So in this condition of the gallbladder, which result as a complication presence of gallstone, 90% of cases it as a result of obstruction. Okay, where obstruction of neck or cystic duct of the gallbladder, obstruction of neck or cystic duct of the gallbladder. So it can be either due to obstruction at of cystic duct of gallbladder or at the level of neck of the gallbladder. Next, the mechanism of inflammation in acute calculus cholecystitis. Acute calculus cholecystitis is the main reason is obstruction. So what is obstruction? Obstruction result in increased intradermal pressure. So here increasing intradermal pressure which result in enlargement of gallbladder, and thereby there is disturbance of motility of the gallbladder, which ultimately leads to obstruction of venous flow and ischemia. So this ischemia result in mucosal injury. So this is the particular type of inflammation is due to mechanical cause, that is obstruction. So this one is the mechanical cause. So here obstruction result increasing intradermal pressure which result enlargement of gallbladder. Thereby there is a disturbance of that motility of the gallbladder, which ultimately leads to obstruction of venous flow and ischemia. And this ischemia result mucosa injury. This particular type of inflammation is due to mechanical obstruction. The second mechanism which are going to understand is because of phospholipase which are released from the mucosa. Phospholipase which are released from that mucosa, they convert the biliary lecithin, to lysolecithin. This one biliary lecithin is converted into lysolecithin. This lysolecithin is very toxic to the mucosa of the gallbladder. This lysolecithin is very toxic to the mucosa of the gallbladder, and once it is toxic to the mucosa, there is loss of productive mucus. So loss of productive mucus where the mucosal epithelium will be exposed. Mucosal cell exposed, we have toxic component within the bile, which can expose these mucosal epithelial cells. What are these toxic component? It can be detergent actions of that bile salt. It can be the prostaglandin released from the cell itself, even the excess cholesterol crystal can be injuries. So this particular mechanism is chemical injury. So the pathogenesis of acute calculus cholecystitis is basically because of obstruction, and the mechanism might be of mechanical injury or chemical injury. Lastly, there can be bacterial causes as well, but majority of the time bacteria causes is usually a secondary event. The E. coli, Klebsiella, Streptococci, and Clostridium are the usual organism. So secondary causes caused by E. coli, Klebsiella, Streptococci, and Clostridium are the organisms. All these complicate the already inflamed gallbladder because of either mechanical injury or chemical injury. So main injury because of mechanical or chemical. After that only secondary injury only microorganism also causes. Why will there be an inflammation in acute acalculus cholecystitis? So when you don't have stone, what is a mechanism? This type of cholecystitis most commonly occur in very seriously ill patient. The predisposing factor for the development of acute acalculus cholecystitis, or it can be major trauma or major surgeries. After severe burn, it can be severe systemic infection or the sepsis, sometimes even severely immunosuppression individual. Immunosuppressed individual can develop acute acalculus cholecystitis. Then ischemic injury is the most common reason for inflammation. Why will there be ischemic injury? You have a major surgery, or you have severe burn, or you have sepsis. All these can result in hypotension. Because of these are the things, because of major surgery or severe burn or sepsis can result hypotension, and that hypotension might leads to decreasing oxygen supply or reduced flow of blood to the gallbladder, thereby reduced oxygen supply, thereby hypoxia. Then result inflammation. So remember, acute acalculus cholecystitis is the major mechanism is ischemic injury. Now, how does the gallbladder from an acute cholecystitis look like? Both type, whether it is caliculus or acaliculus, it resemble the same except that stone are presented in that caliculus type. So caliculus type plus we have stone, here don't have stone. Then a cross examination that affected gallbladder is usually enlarged and tends it sometimes be very bright color or bright red color. Bright red color. because of various subserosal tiny hemorrhage. Because of subserosal hemorrhage, we can have fibrous exudates or fibrinofluent exudate in the later stage. The lumen of the gallbladder can contain cloudy or turbid bile with or without blood. So this one, the later stage, the lumen of the gallbladder can containing cloudy or turbid bile with or without blood, with fibrin or with pus, depending upon the stage of acute cholecystitis. On microscopy, all finding of acute inflammatory changes we can see in the form of ulceration, or it can be edema of the wall, or it can be neutrophilic cell, neutrophil infiltration throughout. It can be congestion, sometimes it can be necrosis. Ultimately, it can even leads to that gangrene as severe cases. Now coming to clinical pictures. Usually a patient of acute cholecystitis present with progressive right upper quadrant or epigastric pain. The particular pain lasting for more than 6 hours. Usually accompanied pictures on examinations, tenderness and right subcostal region due to spasm of abdominal muscles. Rarely distended gallbladder can be palpitate, which is tender. Next, what happen if the root cholecystitis is not recognized and treated? First and foremost, acute inflammation increases. First and foremost, acute inflammation increases. Then neutrophilic infiltration is there is within the wall of the gallbladder, and the bile become infected. The bile become purulent in the later stage, and the entire gallbladder is filled with pus, and that is called as empyema of gallbladder. If the inflammation continue, if there is lot of congestion and necrosis and suppurative infection, suppurative infection, it can result gangrene. So gangrenous cholecystitis, gangrenous cholecystitis, first formation suppurative infection. Then emphysema cholecystitis can also be a possibility when it is infected with clostridial infection. Already discussed, if the content is too much, the gallbladder cannot contain it. It can result in perforation that may lead to peritonitis, fistula formation. It also possibility which can really leads to gallstone. Ileus repeated attack of mild acute inflammation can result in chronic cholecystitis, and long-standing irritation can result in development of carcinoma of gallbladder. So here may leads to peritonitis, fistula formation, also possibility. Then leads to gallstone. Ileus repeated attack of mild acute inflammation can result chronic cholecystitis, and a long-standing irritation can result in development of carcinoma of gallbladder. Now coming to chronic cholecystitis. It is most common form of gallbladder disease. Why does this occur? This can be occur because of repeated attack of mild acute cholecystitis. This one occur because of repeated attacks of mild acute cholecystitis. It is almost always associated with gallstone. Hence, the epidemiology, the risk all are similar to that of gallstone. The pathogenesis of chronic cholecystitis, it is because of recurrent mild attack. Pathogenesis of chronic cholecystitis, it is because of recurrent mild attacks of acute inflammation due to the stone. We need to understand that the intensity of that inflammatory response induced by gallstone in different population varies, and it is genetically determined. Why do we say this? Because there is a very poor correlation between severity of the inflammatory response and the number and volume of stone. Some population responds very minimal to the large number of stone, and some population exhibit a very florid response resulting in severe inflammation or fibrosis. So there is always a genetic component in determining the outcome of a complicated gallstone. The morphology of chronic cholecystitis. Crossly, the gallstone can be normal in size, or it can be distant, or it can be stringent. But most often it is stringent. Usually, it will have thick wall, but sometimes it can be thin. Usually the cirrhosis surface is smooth and shiny, but it can be dull, and the reason for this varied appearance is a reflection of different in degree of inflammation and fibrosis, which we discussed earlier. The lumen, uh, the lumen of the gallbladder, most often stone is seen. So often gallbladder stone is seen. Multiple stone can be seen. Microscopically, the following features are necessary for diagnosis of chronic cholecystitis. One predominant one mononuclear cell infiltrate in that lamina propria, which can extend into muscularis and the serosa. Already discussed mononuclear infiltrate, it can be lymphocytes, the plasma cell, and macrophages. Anything can be there. Then fibrosis and metaplastic changes should be seen, and another important fibrosis and metaplastic changes. We can see outpouching of mucosa mucosal epithelium through the wall of the gallbladder. Okay, so here outpouching of mucosal epithelium through the wall of the gallbladder, and these outpouching are referred to as Rohidensky as of sinuses. So Rohidensky as of sinuses. This one is the microscopic view. This is the microscopic image of chronic cholecystitis. Here we can see that mucosa outpouching. This one name is called Rogitskin adsorb bodies, mucosa outpouching. Then subserosal fibrosis, outpouching are trapped in the muscularis layer under this rogidan sky of bodies. Here you can look at that amount of chronic inflammatory cell infiltrate. This one inflammatory cells infiltrate. All these are lymphocytes and plasma cell infiltrating into the various layer of gallbladder. Next complication of chronic cholecystitis. One is acute inflammation can be super added over a tonic inflammation. That is when we call acute on chronic cholecystitis. Acute on chronic cholecystitis. Sometimes diffusely intramural dystrophic calcification can be seen in gallbladder. That is referred to as four-line gallbladder. Risk of malignancy is always there in the long-standing cases resulting development of gallbladder carcinoma. So complication here, acute inflammation can be seen in super added inflammation. That condition name is called acute on chronic cholecystitis. Second, sometimes diffuse intramural dystrophic calcification can be seen. That one name is called as four-line gallbladder. Then risk of malignancy, gallbladder carcinoma. So this is all about cholecystitis, acute and chronic cholecystitis, inflammation of gallbladder. Thanks for watching.